Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from B1.
Hello everyone, my name is Dr. Toby Eyre and I'm a consultant haematologist at Oxford University Hospitals NHS Trust in the UK. Welcome to this programme entitled Charting the Course in CLL, a clinician's compass for BTK inhibitor therapy. Now, I'm delighted to be joined today by two expert faculty, Dr. Tal Munir, who's a consultant haematologist at Leeds Teaching Hospitals in Leeds in the UK, and Professor Anna Shu, who works in the Department of Oncology at Oxford University in Oxford. Welcome, both of you.
Thank you.
So in this activity, we're going to review the use of BTK inhibitors for treating patients with CLL in the UK and give a brief update on some of the latest data from key clinical trials. And then we'll go on to discuss some example patient cases and decide together what would be the optimum treatment for these patients and how the available clinical data supports the treatments that we're recommending. So to begin with, we're going to focus on the role of BTK inhibitors for treating CLL in the UK. Now, Tal, over to you. Which BTK inhibitors are approved in the UK and available for us to use for treatment for our UK CLL patients?
Thank you very much, Toby. So the BTK inhibitors that are approved and available to use in the UK includes the first-in-class BTK inhibitor, ibrutinib, which can be used as a monotherapy treatment and in combination with venetoclax as a fixed-duration therapy. And then we've got options of acalabrutinib, zanubrutinib, which are the second-generation BTK inhibitor. And then we've got the new class of the drugs, the non-covalent BTK inhibitor in the form of pirtobrutinib. And I think those are the main BTK inhibitors that we can use in UK at this moment in time to treat CLL.
Yeah, thanks, Tal. So lots of development in this space. What do you think the key differences are between the BTK inhibitors that we've seen in development that we can now use?
So there is some quite a lot of differences, but similarities between the BTK inhibitors. They are all mostly oral drugs, and the most important thing to remember is that the class of the drug is different. So the first generation and second generation BTK inhibitors were covalent BTK inhibitors. They form a covalent bond to the cysteine 481 residue, and as a result of that, they inhibit the signaling through that. Their selectivity is different as well. So some of the BTK inhibitors, like ibrutinib, is blocking multiple kinases, where acalabrutinib is a bit more selective, but the metabolite of the acalabrutinib does have a bit more inhibition of other kinases, and zanubrutinib somewhere falls in between the two. And with the pirtobrutinib, you've got the non-covalent BTK inhibitor binding, and as a result of that, you are seeing a different kind of spectrum of responses, but also in terms of the mutational landscape is different when we're using pirtobrutinib. And then there are subtle differences in terms of the adverse event profile of these molecules as well. For example, we have seen a little bit more cardiac toxicity with the first in class of BTK inhibitor, which was ibrutinib. Whereas with acalabrutinib and zanubrutinib, the cardiac toxicity is less. And in terms of the pirtobrutinib, although the data is short, we are seeing less cardiac toxicity. But apart from that, acalabrutinib gives you headaches. We see more neutropenia with zanubrutinib. So there are subtle differences in terms of adverse event profiling. And the dosing or dose modifications are also different between the different BTK inhibitors. For example, ibrutinib is once a day tablet. acalabrutinib and zanubrutinib, as well as pirtobrutinib, are twice daily dosing, and the dose modifications are slightly different between the different BTK inhibitors.
Great, thanks very much, Tal. What guidelines are used in the UK to guide the use of BTK inhibitors? You mentioned, obviously, we have a range of choice now, and navigating the different options is somewhat challenging. What guidelines do we have, and what are the key determining factors within those guidelines for selecting treatment for patients with CLL?
So in terms of guidelines, we have got the 2025 BSH guidelines, and we are looking at multiple factors which are helping us to decide treatment options. So one of the most important features of the guidelines is the incorporation of some of the CLL-related factors, especially the genomic profiling of CLL, so like the IGHV status and the TP53 aberration status right up front. Also looking at the bulk of the disease as well, because that can help to choose therapies. And then obviously in the relapse refractory setting, we don't really have a lot of data what is happening to our patients after fixed duration therapy, and we will talk a little bit about that later on. And then the question of intolerance on a BTKI inhibitor versus progression on BTKI inhibitors. But I think the guidelines also talk about the patient vulnerabilities in terms of the cardiac side of things, also the use of anticoagulants, the renal disease, the risk of autoimmune complications. All of those factors need to be taken into account. And lastly, the most important thing is patient preference, which is, I think, one of the cornerstone of how we are choosing therapy for our patients. So I think the guidelines are very concise in that respect, but does open up a lot of factors for us to consider before choosing the right therapy for our patients.
Yeah, thank you very much, Tal. Certainly lots to consider when we have increasing numbers of therapy available, and certainly patient priorities and preferences, I think, are key in those decisions. Thank you. So now we're going to turn to Anna. Anna, it would be great if you could give us a brief overview on some of the latest key data really investigating these different BTK inhibitors in CLL. There's obviously been a lot of activity here, lots of clinical trials. I wonder if you'd be able to give us a quick update on some of the latest findings from the key clinical trials of BTK inhibitors in this space.
Yeah, thank you very much, Toby. As you said, there's been quite a few updates in the last year, starting with the Sequoia study. Just to remind you, this was a study that randomized treatment-naive patients between zanubrutinib and bendamustine and rituximab. And for me, the main take-home message there was that the 60 months or 5-year progression-free survival rate was quite impressively at almost 76 months, and very similar for the people with TP53 aberrations. The next study was the Alpine study, where we had a final efficacy analysis based on IRC. This was again a phase 3 randomized study, and in relapse refractory patients this time, comparing head-to-head zanubrutinib versus ibrutinib. And this was a very interesting study, particularly, I think, because of the showing the different side effect profiles, and we've learned a lot from this head-to-head comparison. However, it also became apparent, although the study was originally designed as a non-inferiority study, that there was actually an increased progression-free survival benefit with zanubrutinib compared to ibrutinib, and that was sustained with a median follow-up now of 42.5 months. Following from there, we've had very interesting data on pirtobrutinib in the Bruin study. This again was a randomized phase 3 study in relapse refractory CLL, and importantly, this was exclusively a study in previously in patients previously treated with a covalent BTK inhibitor. And it's interesting because if you remember the Murano study on venetoclax and rituximab, that study primarily included patients who had received prior chemoimmunotherapy. So the main data we have on venetoclax in the relapsed refractory setting is based on chemoimmunotherapy patients, whereas here we have patients previously treated with a BTK inhibitor. So, quite impressively, the median progression-free survival was in the order of 14 months with pirtobrutinib, and that compared favorably to the control arm, which was investigator choice, idelalisib rituximab or bendamustine and rituximab. Most patients in the study received bendamustine and rituximab. The Elevate treatment naive study reported the final 6-year follow-up. So this was a study looking at acalabrutinib as a monotherapy and in combination with obinutuzumab, and then comparing this against cloambucilin obinutuzumab. And the study, this 6-year follow-up report essentially confirms what we already know, which is that clearly acalabrutinib combinations were superior, very much superior to the chemotherapy in this frailer cohort of patients. It again showed this advantage of adding obinutuzumab to acalabrutinib, although that was again not really statistically significant in terms of the PFS. There was an overall survival benefit also with the obinutuzumab combination against the chemoimmunotherapy. The Captivate study, switching over now to the combination fixed duration therapies, so ibrutinib and venetoclax, fixed duration therapy in a cohort of patients who were treatment naive and what we would say fit, younger patients. Again, the longer follow-up confirmed very impressive progression-free survival rates of 66% at 5.5 years. Interestingly, also now there was for the first time data presented on what happened subsequently to the patients. So some patients who relapsed received ibrutinib retreatment, which was effective. So 25 received ibrutinib as a single agent and had a 2-year PFS of 91%. And then retreatment with the doublet in 11 patients had a PFS and OS of 100%. So clearly demonstrating that a retreatment both with single agent and as a doublet following on from relapse from the doublet is effective and possible. Interestingly, also there were no resistance-associated mutations when this fixed duration therapy was given. The FLAIR study has now had many publications, and it's a very significant study, obviously for us in the UK. It clearly shows that in particular for the immunoglobulin unmutated patients, the MRD-directed ibrutinib venetoclax had a PFS and overall advantage, both over ibrutinib and FCR. So for me, that remains really the key message, that there is an overall survival advantage of the doublet versus the single agent ibrutinib. At 2 years, undetectable MRD in the bone marrow was achieved by 66% of patients, which is a very impressive rate of MRD. Importantly, also the overall number of deaths was lowest in the doublet arm compared to both the FCR arm and also the ibrutinib single agent arm. Shortly after the FLAIR study, we then had another publication in the New England Journal of Medicine on Amplify. This was a 3-arm study comparing acalabrutinib, venetoclax, obinutuzumab with the doublet AV, and then the FCR-BR chemoimmunotherapy control arm. And among all the available patients in the AV and AVO arm, the undetectable MRD rates in the peripheral blood were durable up to 36 months after the end of treatment. And then last but not least, there's more data has been published now on zorotoclax, which is BCL2 inhibitor, and that is similar but different from venetoclax in that it has a shorter half-life and no drug accumulation. So after the single drug dose escalation study, they then combined it quite quickly with zanubrutinib, with a very impressive 30 months PFS rate of 94.7%, clearly highlighting the fact that this drug combination is very promising and obviously already being going now into phase 3. The drug itself was very well tolerated. There were no serious tumor lysis problems noted during the study, and I'm pretty sure that this is an interesting combination which would be very good for patients.
Anna, thank you so much for that excellent and very rapid overview on a lot of clinical studies. And we're going to flesh out some of those points now by walking through 3 patient scenarios. So I'm going to present each case and then come to Tal and Anna for comments. So the first case is a 75-year-old patient who presents to clinic with worsening anemia and thrombocytopenia. He's also increasingly fatigued. He's generally been fit and well with a good performance status, and he's had his immunoglobulin gene mutation status checked, and he's got unmutated disease. He has TP53 wild-type disease and has no deletion 17p on FISH testing. His white count is now 90, his hemoglobin is 75, and his platelets are 80. There's a history of well-controlled type 2 diabetes, osteoarthritis, and a history of hypertension. Tal, if I could come to you first, given the patient-related factors, the patient comorbidities, and the CLL-related factors that are outlined in this case, and as you were talking about earlier, what would really drive your decision making in this instance, and would you consider a BTK inhibitor for a patient like this?
Yeah, would definitely consider a BTK inhibitor in patient with this kind of picture. I think the important thing really is few CLL factors. You know, obviously patient is anemic and thrombocytopenic, so one has to exclude autoimmune side of things as well, considering if there is no autoimmune flavor to the presentation in terms of options that we can give to this patient is fixed duration therapy is an option for this patient, but you have to consider that he's got unmutated IGHV status. So whichever fixed duration therapy we're going to offer this patient, the outcome, the 5-year outcome, might not be as good as with a continuous BTKI inhibitor approach. And if I have to choose a continuous BTKI inhibitor, it would be a kind of a toss between acalabrutinib and zanubrutinib, really, and that's the main option that we've got for this patient at this moment in time. And I think really in terms of what to choose between the two is very difficult at this moment in time because there is no head-to-head data. So what I would look at is the comorbidities in this patient and really look at the hypertension risk that this patient has got. Is he already on 2 or 3 antihypertensives? If he's already on that, I may err towards acalabrutinib. But if the hypertension is not too much of a problem, and I think I can easily choose zanubrutinib for this patient as well. So the options are pretty good from this perspective. The main question we need to answer or the patient has to be given a choice about fixed duration with slightly inferior results at 5 years as compared to continuous BTKI inhibitor. And if the continuous BTKI inhibitor is the approach we're going to take, then really it's a question about looking at the side effect profiles of individual molecule to make a decision.
Great, thanks very much, Tal. So if you choose a BTK inhibitor, be it acalabrutinib or zanubrutinib, what are and you've touched on some of this, but what are some of the adverse events that the patient should be informed about before starting treatment, and how do you monitor those adverse events in your clinical practice?
So in my clinical practice now, for any patient starting on a BTKI inhibitor, we do a baseline ECG in all our patients and usually do an echocardiogram for these patients as well, especially at this age, which I think has become more of a kind of a normal practice for most of the clinicians as well. I think if I'm choosing acalabrutinib, I will very well mention headache as a short issue with the acalabrutinib, and talking about using caffeinated drinks is quite important for these patients so that it doesn't come as a shock to them. With zanubrutinib, I would be talking about a little bit about diarrhea and arthralgias, but also mentioning that neutropenia could be a side effect that we might see with the drug initially, but that is very much manageable. Long term, I would talk to all my patients about atrial fibrillation, risk of atrial fibrillation, and the need for anticoagulation and how it could be difficult, as well as monitoring for high blood pressure, especially with zanubrutinib, and that would be the cornerstone really of the discussion right up front. I think one thing I always talk to patients about is the risk of infections, and because that is going to be inherent to any treatment that we give to our patients.
Excellent, Tal. Thank you so much. Let's move on to case number 2. So case number 2 is an 81-year-old lady who's been on first-line treatment with ibrutinib for the past 3 years. And she started this treatment initially due to Binnet stage C disease associated with IGVH unmutated status and a TP53 mutation. She's developed hypertension requiring 3 different antihypertensives and has also complained of increasing arthralgia over recent times. She has recently had a normal CT scan and a normal full blood count, so she is in a good radiological and clinical remission. So Anna, if I could come to you, as this patient appears to be somewhat intolerant of the ibrutinib, what would you discuss in your clinic, and what might be your next steps here?
Yeah, thank you. I think it's really important that we differentiate between resistance and intolerance. So we've established that she's intolerant to ibrutinib, and she has got developed quite severe hypertension. As Tal has already pointed out, I think it's important to involve cardiologists in the management of our patients. Not everybody, but at least in someone who has got 3 different antihypertensive therapies. You know, what does the echo show? What does the ECG show? But all things being equal, I would probably say to the lady that we would stop ibrutinib and we would start instead a second generation covalent BTK inhibitor. And the reason why I'm saying this is because there's been quite some data over the years showing that there's not always a cross intolerance. In fact, most patients would when they switch, the adverse event even either decreases or completely disappears with a switch to a different BTKI. So I would be quite optimistic that we would get this under control. She has got TP53 mutation, so I would steer away from a fixed duration therapy for that reason, because we know that patients with TP53 abnormalities benefit more from continuous therapy. The alternative here would be venetoclax rituximab over 2 years. The issue there is that we don't have actually much data supporting the efficacy of venetoclax combinations following on from ibrutinib. And although this is what we do, and although we tend to switch in that way, but I wouldn't do this here because she is intolerant, and also because she has got TP53 mutation. So I would hope that her side effects will improve. And then the question really is how would this affect future therapies? I think because she's 81 years old, the median progression-free survival on a BTK inhibitor, I would say, in this lady would be in the order of 5 to 7 years, really. At that point, she's almost 90, and it's an oral therapy. She doesn't have to come into hospital for intravenous therapies. Those things are also important.
Yeah, thanks very much, Anna. And just briefly, a couple of other quick questions. So would you ever consider giving a patient a break here before starting another covalent BTK inhibitor, for example? Or would you always switch immediately?
There's not much data on stopping, especially not in patients who have got high risk disease like herself. Clearly, there's no urge. I think we saw initially with ibrutinib in particular, we saw when relapsed refractory patients stopped it, we saw this flare of disease. We don't really see that much in frontline. She's been on ibrutinib for a long time. She's in a complete remission. I'd be quite relaxed on restarting, but I wouldn't sort of give her like a formal holiday. I would go in and continue sort of seamlessly.
Thank you. And if you could use pirtobrutinib, would you ever use a non-covalent BTK inhibitor before at the point of switching here, or do you stay within class and stay within a covalent BTK inhibitor?
I would stay in class. As I said earlier, the Bruin study obviously was a study that was exclusively recruiting patients who'd previously been exposed to BTK, to covalent BTK. So we know that pirtobrutinib works in this setting. And here it's exposure, it's not refractory, but I would exhaust the options of a covalent BTK first before going on to the non-covalent.
Okay, great. Thank you very much, Hannah. So moving on to a younger patient, case number 3. So a 64-year-old patient with IGVH unmutated disease was treated with ibrutinib and venetoclax according to the licensed treatment indication of fixed duration therapy for 15 months at approximately the age of 60. So he obtains a 3.5-year remission, but actually then relapses quite quickly within a few months, requiring second-line therapy. So the questions here are really about what treatment you would recommend and whether the duration of that first remission influences your approach here. So Tal, if I could come to you and get your thoughts.
Yeah, I think that's a scenario we are kind of getting used to now, Toby, because we are starting to see these patients who have fixed duration therapies, and some of these patients who have got more proliferative disease are starting to relapse pretty quickly. I think the timing of around 3.5 years of remission, probably post finishing I+V, is reasonable for us to consider similar class of drugs again. So the only data that is available at this moment in time, and Anna kindly showed some data from Captivate, as well as there's some data from Glow, that when we use the similar class of drugs like a continuous BTKI inhibitor, these patients do respond to to ibrutinib, or some data for reusing I+V. Now, the issue we have got in the UK is that we can't use I+V again, but we can use covalent BTKI inhibitors again. And again, I think when you're looking at single agent data based on Elevate relapse refractory study, as well as the Alpine study, it's pretty clear that our choice would be between acalabrutinib and zanubrutinib in this setting. Now, one can argue that we can use venetoclax rituximab in this setting as well, but that is not based on any data at this moment in time. There is some published data that is based on case reports where patients are salvaged with retreatment with venetoclax. But at this moment in time, we are in a hiatus of very poor evidence in this space at this moment in time. So I would choose a covalent BTK inhibitor continuous therapy in this patient. But then I will also think about a 64-year-old guy who's had two very potent drugs and relapsing pretty quickly, and would very carefully monitor for any relapse, because this patient might need more salvage therapies in future. And we really need to get these patients on a clinical trial if possible, so that we can get a better output from how these patients are going to do in future.
So thanks very much, Tal, on your thoughts on case 3. Just to move now to the final thoughts and conclusions of our topic. So we've talked quite a lot around different covalent BTK inhibitors, non-covalent BTK inhibitors. It'd just be good to get your final perspectives on how you might personalize those for our CLL patients, particularly focusing on second generation BTK inhibitors. So Tal, if I could come to you first.
So my view on covalent BTK inhibitors are that they have been the game changer, cornerstone of the change in therapy for CLL. I think we have got very long-term follow-up data on these molecules now, and we know what to expect from these molecules now. So for frontline patients, regardless of the genomic alteration, the covalent BTK inhibitors are giving durable responses for majority of the CLL patients. So you can quite easily take the approach of using these molecules for our patients. But now we have got the propensity of combining these molecules and using them in a fixed duration approaches and other derivative approaches where essentially these combinations are producing quite durable responses. And the non-covalent BTK inhibitors are one more in our armory. So essentially, we have to choose the therapy based on the genomic profile, but patient preference is becoming more and more important. And the first line therapy is becoming a very important decision that we need to make for our patients, because that will dictate how we are going to treat those patients on subsequent lines of therapy. So I think the landscape for CLL treatment is very fertile, and actually it's very good for our patients, and the choices apart from chemoimmunotherapy are great.
Great. Thank you, Tal. And Anna, any final thoughts?
I think it's really important because we have all these drugs available now that we are still really recognizing the treatment indications and that they haven't changed. And so we're still treating patients according to IWCLL guidelines and not any sooner than that. So which basically means some stage B patients and clearly all stage C patients, and they have to have symptoms. So I think that's important. On the other side of the spectrum, I think pirtobrutinib is appearing as a very good bridge to transplant, for example. And so I would also think about those high-risk patients as they're coming through the system. As Tal said, we don't have much data, we don't have much to offer them. And in addition to designing clinical studies for those patients, I think it's also important to bear in mind that we do have increasing the drugs now that we can use as a bridge for salvage therapy, including pirtobrutinib.
Great, thank you. Excellent. Well, thank you so much, Anna and Tal, for this great discussion. And thank you to you for participating in this activity. Please do continue on to answer the questions that follow and complete the evaluation.